On behalf of the North Dallas Chamber of Commerce, I want to welcome everyone here today. This is our healthcare committee, which was founded just right about the beginning of the pandemic. I think it was about a month before that, where we had our first meeting of the healthcare committee. And it's a collaboration between the North Dallas Chamber of Commerce and the Health Industry Council Foundation, represented today by Kenya and Ben Isger. So today we really wanted to bring people together. We're trying to meet quarterly in between our annual healthcare conference, which typically occurs in January. So in that particular case, we said, let's get a program on the books here. There couldn't have been better timing because Ben was just coming out with some great research on the topic du jour. So we're going to go ahead and get kicked off. So I'm going to turn it over to our incredible moderator, Kenya Woodruff. And Kenya, why don't you go ahead and take it away?
All right. Well, I love our title, Secrets of Healthcare Pricing Revealed. I feel like I need like some great music coming in the background. What are the implications for providers, employers, and consumers? And if you guys are like me, and I'm a partner in a healthcare practice, we are fielding these questions and everybody really wants to know what everybody else is doing. So that's why Ben's report is going to be so helpful. Everyone's kind of struggling with what to do from a practical and operational standpoint, as well as from a PR standpoint. We have Tom Peck on, maybe that can chime in on some of those aspects. We have two great speakers today who are going to talk about this issue. One is Ben Isger. He leads the PwC's Health Research Institute. HRI is a dedicated research group that provides new intelligence, perspective, and analysis on major health-related business issues. In this role, he oversees thought leadership and research initiatives for the firm and clients. Prior to joining PwC, he developed health policy as a legislative director in the Texas House of Representatives and as a government relations officer for the city of Austin. We also have Kristen Tesmer, who is the Chief Executive Officer of Dallas Medical Resource. She supports Dallas prominent business leaders, health system executives, and healthcare thought leaders in their efforts to promote a healthy safety net for healthcare in North Texas. She's a licensed attorney with an MBA focused on healthcare management. She also has extensive experience in healthcare policy, physician relations, and healthcare management. I've had the honor to work with both of them on different boards in different capacities, and you are in for a treat today. So Ben, if you start with our overview, then we'll follow up with our conversation.
Will do. Thank you, Kenya. And I will share my screen. So those of you that know me, I always have at least a few slides to share from our research. So I can't disappoint in that sense. And I have to say, I don't know about you all, but I love the way that Ken starts out every meeting. I always feel like, it's like the baseball, walk-ups where you just get pumped up as he recognizes each person as they come in. So in these times of Zoom meetings, you make it fun, Ken. So thank you. As Kenya mentioned, we have a kind of a fun title, right? Secrets of Healthcare Pricing Revealed. And I think that the title around this is there for a simple reason that a lot of healthcare pricing is opaque. I know many of you all are health executives running, big organizations. This is something that, I'm not revealing anything that you haven't heard before, that pricing is often opaque, and it's really often opaque for consumers. And we will think about that question of, are consumers really the right people to deal with pricing, or should it be somewhere else? But we've got something on the table, which is we've got new rules around price transparency that are in effect, and some more that will be in effect as time goes on. And really, that's what my 15-20 minutes here is all about, which is just to kind of set up a little bit of framing around what's out there and what some of our research has shown. One bit of background besides the opacity of pricing, which is generally a known fact in healthcare. The other just kind of macro thought I would throw out there is when any organization, any payer, whether you're a consumer, government, or a private payer, or an employer, is looking at how to reduce overall costs, we have over the long term, as in over the last 20 years, mainly focused on the utilization part of cost. And so more cost sharing, more deductibles, more copays has generally kept utilization in check, or at least kept it from growing very much per capita over the last couple of decades. But what is being revealed more and more is that to bring healthcare costs down, that's going to have to rely more on the price side of the equation. And so that I would say keep that in mind as well, that we can't really keep going back to the well of more cost sharing for consumers, because eventually that has diminishing returns, and in fact can actually have some of the opposite effect of what we want, where people forgo care that they actually really needed. So here we are. Just here's the three major changes we see out there. One went into effect as of January. That's the hospital transparency rule. I'll be talking about that. Effective next January, the insurer transparency rule. By the way, both of these were done under the Trump administration, and will be carried out under the Biden administration. There's a question about, will the Biden administration do anything different with the rules, especially the payer transparency rule. But generally, the stuff has some sort of, it typically has some bipartisan support. One issue I'm not going to cover today, but that's in the report and I think does actually fit very closely with these other two rules, is the No Surprises Act, which is scheduled to go into effect in January of 2022. I won't cover that, but it is there to look at as well. So on the hospital pricing transparency piece, again, some of you may already know some of this, so this will just be kind of a refresher. What exactly does it ask hospitals to do? Well, they've got to have machine readable files. So these are files that a computer program can go in and dump that data into a format that can be easily manipulatable. So that actually, can help with assessments of that data. And so machine readable files that have things like payer specific negotiated rates, charges, discounted cash prices, and a minimum and maximum charges. So a lot of data that we don't normally see out there. The other thing hospitals must do is they have to provide a lot of this information in a consumer-friendly format with pricing information for 300 shoppable services. Just one further refinement on that. 70 of those services are pre-required. So the government's saying which of 70 services you must provide that pricing information for that's, quote, shoppable. And that's things like a metabolic panel to gallbladder removal. So they've got 70 in there. And then the hospital can pick the other 230, presumably. So that's really what's in the rule itself. Let's look a little bit in terms of what some of our health system executives have said. So what they've told us back in 2020, this last summer, summer of 2020, 76% of our provider executives said their organization is already developing a pricing transparency strategy that is aligned with improving the patient experience. So hospital leaders, this is nothing new to you. You've got some consumers that want better pricing. They can be sometimes frustrated with it. So again, this is something that has been brewing for a while. If we went back even farther, look, this is not new. Individual states have had their own pricing rules, in terms of posting and things like that. So not a completely new concept either way. They say about 70% of our leaders said that they thought that they would be in compliance with the rules by 2021 when we surveyed them in 2020. Now here's the big reveal. So what exactly has been going on so far? And I want to say so far, to be fair, the data I'm showing you here, we gathered back in February and March, and there's actually a lot that's moving on. And so a lot that's being done kind of day by day. So some of this may have already changed. What did we do? Well, I have a team of research analysts, and we sent them out to basically do kind of some secret shopping, if you will. Really, it's just going to all the websites and analyzing the type of information that's on the websites in relationship to this rule. And we went to 102 hospital websites and did this. And we tried to do a mix of larger hospital systems, smaller hospital systems, AMCs, rural. This tiering, this is our take on tiering. This is not a standard that's out there, a regulatory standard. But we said, okay, tier 0, that means you really haven't done anything yet. So you don't have data out there in a machine readable format. It's easily accessible. And then we worked our way up through tier 1, tier 2, and tier 3. And again, it's just basically how aggressive is your compliance with the existing rule. And so you can see tier 1, they've got a little bit of stuff up there, tier 2, more, and then tier 3, they really, in kind of from what we saw it for our secret shopping, they really had what we would consider full compliance. You can also see the breakdown, not just by the tiers down below, but also the type of organization that we looked at. What's the takeaway here? Well, it's really kind of all over the map. I think the takeaway here is that there's a lot of things in motion. That there are some health systems that have been very aggressive in compliance. Probably many of them may have already had some compliance requirements previously on the state level, or because of consumer demand, had already begun that. Getting into just like some screenshots of what are we talking about here? So here's one example. Obviously, all these examples are blinded, where we're looking at standard charges for a colonoscopy. This one is one we considered more thorough. It has a lot of the all of the data points in terms of the requirements around charges and whether it's self-pay, the maximum, the minimum, all of that listed out. Okay, as a consumer, still a lot to think about here, because you'd really have to know a lot of detail about your colonoscopy, right, in order for this to be incredibly useful, at least from a consumer standpoint. Other examples out there, much harder to deal with, and just to be fair, again, we're showing there's a lot of difference out there in terms of compliance. And so here we're seeing, sometimes information that's kind of obfuscated would be very difficult for marine machine readable format. Certainly very difficult for a consumer to read in terms of the way that the data was placed out there. So just some real life examples of the way that we're seeing this being done. I think this brings up a really important question. And I think many of you who are provider leaders out there are probably saying, look, even with full compliance, is this going to be useful for consumers? And that's an absolutely fair question. About a third of consumers that we surveyed in the spring of 2020 said that they had shopped around for the lowest cost primary care option in the past 2 years. Granted, it's a little bit easier to shop for primary care. We see virtual health, retail health, clinics, hospitals, physician offices often do have a more transparent primary care price list. Taking it up a notch in terms of just consumers, these are broad generalizations. Obviously, we've cut the data a lot of different ways, but just if you had to just kind of do some of these broad archetypes of who's most likely to shop based on price for healthcare versus least likely to shop, some of this may be kind of interesting, right? I mean, least likely to shop Medicare. They're not shopping around. They know exactly what their out-of-pocket is going to be in most cases. Most likely to shop around people that are uninsured or people who have purchased directly from health insurers through an exchange plan. And I think that makes a lot of sense. Like kind of intuitively, they're probably going to have a higher deductible, right, than maybe an employer-based plan. And so we're going to see, or a Medicaid. So we're going to see a lot, potentially more shopping around there. Least likely to shop for lab work. People are more likely to shop for major or minor surgeries. I think especially elective or something that at least is not emergency or pressing. You've got some time to think about it. Maybe you have a high deductible. Again, you're starting to look around. Most likely to shop using an online tool provided by a health insurer. Least likely to shop are those that are calling around and asking for quotes, right? So that might be our Medicare population. The age groups, again, probably break out very intuitively. Younger folks are more likely to shop. They may have fewer resources, higher deductibles, also just more comfortable shopping around. They're already doing it for transportation, vacations, and things like that. This one I found interesting, a little bit counterintuitive, at least to me, you all may think differently, but most likely to shop, people in our healthy families category with dependents under 18. I thought that was interesting. The relatively healthy folks already, they probably don't need a lot of care. A lot of that's probably primary care that's happening. Least likely to shop, those with chronic conditions. And so some of those folks might already be on Medicare or Medicaid, but it does get really interesting when we start looking at those consumer demographics there. Okay, let me just make sure. Okay, yep, let's move on to our payer piece here. And so this one doesn't start until next year. And it's got some similarities there. Again, back to the machine readable files, back to being posted online, having to provide negotiated rates for your in-network providers, historical payments, bill charges, out-of-network providers. And then interestingly enough here, this is what's going to be, I think, crucial, in-network negotiated rates and historical net prices for all covered prescription drugs at the pharmacy location level. So again, I think this is where we're going to start to see a lot of the drug costs become more transparency as well, have more transparency as well. When we move to 2023, some new requirements around online tools with cost sharing and the underlying negotiated rate. That's when we move up to 500 covered healthcare items and services, including prescription drugs. Just as an aside, these rules also allow payers to take credit in their MLR calculations for shared savings with consumers if they have a program that's going to encourage them to shop for low-cost care. So some opportunities there as well. So just the net here, if I had to summarize it, what do we think that payers and providers are going to be thinking about during this ramp up to more and more compliance and what are the implications around that? Well, one is around data and just the simple question: are you ready to post all this information and posting it in an easy to read format? Some people are going to be looking at what their competition is doing, and that could be for twofold. One is are you providing a better experience around this data than your competition? The other thing is, how do I compare in terms of my competition in terms of the prices that I'm getting, the reimbursement I'm getting? And this is where I think it gets really interesting in the sense of there's several economists out there that are saying they're not convinced this is actually going to lower costs at all. In fact, it could create a floor, and actually the result could be higher costs overall. So that's, I think, let's put a TBD pin in that, because there's that's the economists on one side versus the other thinking about that. The big question under number 3, do consumers really have the context they need to understand prices? And that goes back to my original point of, are consumers the ones we really want to be on the hot seat for shopping around, or should that be the employers and others that are now using pricing data to actually get better prices and do things like narrow networks and really at what I call the wholesale level? Telling your story, I think this gets to the point around reputational risk and issues. And so no one wants to be the health system or the payer or any organization that's the last to comply with something or doesn't do a very good job with it. So I'd expect that we'll see some of this open up into the media and press. Pricing stories are very popular. Many of you, if you listen to the radio, you might be hearing about kind of bill of the week or bill of the month, things like that. More negotiations that could possibly come out of this as again, there's more pricing data available. And we see some non-traditional health firms are already going out there and scraping this data off of websites. They're the ones that are helping sometimes employers and others and consumers. They're the bolt-on that's helping with pricing as well. Okay, one last thing, and then I'm going to shut it down here. Just a point about the drug costs that I wanted to bring up and medical devices. We actually think there's going to be an effect in the pharmaceutical and life sciences space and an effect in the medical device space. As we have more transparency around pricing, even with some of these bundles, there will be people that are going to be able to start to kind of peel off what is the exact cost of the implantable or the drug, especially if we're thinking about drugs that are in the that are administered in a provider setting, so in infusions and things of that nature, we're going to have better data around what the drug portion of it is versus what the professional portion of it is. So, and that's going to be the same thing on these devices as well. So new insights there as well. I'm not going to go through all of this because in some ways it's very similar to what we saw in providers and payers. There's just going to be more data out there, reputational risk, will it bring prices up or lower, things of that nature. So I'm going to end there. The full report's available online. There's our website if you want to jot that down, or if you have any specific questions. We're going to jump into a panel and be able to go through all of that. So if you all don't mind, I'm actually going to stop sharing my screen so we can get back and see everyone's faces more easily, and ready to go.
All right, well, I'm going to start, Kristen, by just getting from you what you're hearing from your constituents and what you're hearing from a concern standpoint from the providers, and then we'll shift a little bit more towards the employers and consumer. But what are the provider concerns that you're hearing?
So I thank you, and thank you for a great presentation, Ben. That sets the stage for sure. Thanks for the question, Kenya. I actually have constituencies I talk to who are both business people and healthcare systems. And obviously the healthcare systems are concerning themselves not only with, the effort that goes into doing this, but the practicality of its usefulness and the potential for misunderstanding, which I think Ben has represented well. There is a lot of time being spent in very high-ranking officials of each of the health systems to set these things up and to try to make something intelligible out of them for non-data experts, who could obviously download the machine files and do all kinds of things with them if they wanted, but just for it to be useful to anyone. And that time could be spent on other things, potentially even actually reducing cost directly instead of this indirect method. I think that transparency doesn't bother them, as every provider I've talked to is like, sure, it doesn't mean what you think it does. Let us explain it to you, but we'll be happy to show you this stuff. And I hope that someday we can get to a point where it's useful to somebody. I do think that there'll be a lot of employers using it. And that's when I'll move just to a little bit about what I'm hearing from businesses. I think that many of them, as this comes up, they intend to hire companies who are going to analyze this and try to figure out if they should be insured with somebody else, or if they should be directing their staff differently or narrowing their networks or doing whatever they need. I think insurers, and we have obviously people who are experts on here, insurers, but I mean, they are already representing to people who are insured and on their plans, providers that you can go look at that give a balanced scorecard about quality, cost. It doesn't give you the detail that some of these things do, but it gives you general assessments of different providers and gives some consumer information that's a little more palatable, a little less specific. I think as we move into their world, that might be a little more useful to everybody. And obviously you asked about providers, so I'll wind right back to them on my last comment before we hand off here. But there have been a lot of legal proceedings. Kenya's probably very familiar. The National Hospital Association and others, have problems with some of the items requested, especially at negotiated prices and things like that, and that level of transparency. And I think, that a lot of times the antitrust laws are upside down in healthcare about who's big and who isn't, who's protected and who isn't with those. And so I think that's what those arguments are really about. It's an historical issue. It's not just on this topic. So I throw all that for consideration, and thanks for asking.
No, I think you're absolutely right. When we just start thinking about all of the different constituents that are going to be impacted by this pricing being available, it's really kind of dizzying. We have a question from Harsh, I'm curious to learn about the potential impacts of increasing HSA, health savings account utilization, where people actually pay themselves, thus more aware of cost and service versus going through insurance, and the confluence of potential price transparency. So you have HSA, people trying to figure it out, right? And this price transparency, what is going to be the effect of that? And then, what kind of services do we anticipate seeing, Amazon-like services for the filtering of this price information?
You want to start, Ben? I'll join in.
Sure. Yeah, no, I can take a shot at that. Yeah, first of all, I think it's a great question because, HSAs were supposed to be the mechanism, right, when they were first started under the George W. Bush administration, for more, for consumers having more, skin in the game. This was the ownership society, that you're more in charge of your healthcare. And, I think the data over the years has shown that it has worked, in that manner to kind of a small segment of society. And so most people that are using HSAs tend to be in the higher income category. And it's very unclear whether there's been a lot of shopping around for services because of, of having the HSAs and this savings account that you're building up. And so, you're going to be thinking, because they're all, I should have mentioned, the HSAs are always paired with a high deductible health plan to a certain extent. So ostensibly you're going to be shopping around there. I think it's been very mixed, over the last couple of decades with HSAs in terms of being used for that particular purpose. I think the other piece, though, that Harsha brought up is around the will we see some sort of platform play where consumers will have like kind of pricing and quality data more available to them. I think we do see a little bit of that already with some of the employers who are working with some of those third parties, Castlight, Accolades, Change Healthcare, companies like that are providing some of that pricing data, and they're working with the employer to try to incentivize their employee to go to a lower cost option. The one thing that I think I think providers can feel very challenged, like, oh my gosh, everyone's coming after me regarding this pricing data. The one thing that often gets left out is quality, though. And I will still say that there are organizations that are going to pay because you're the best, and you might have a reason that you are more expensive than the person down the road for providing those services, because actually your outcomes are better. And so I think that's the other play that often gets forgotten in this transparency piece is we see a lot of direct contracting with employers directly to providers who are centers of excellence. And so that's another part of the value equation. So it's not just price, but you actually really need to marry it ultimately with quality as well. So.
Well, isn't that the reason I pay extra for Tide? I mean, there's so many cheaper, there's so many cheaper detergents, but between the branding and the advertising, right, as well as the results I get from it, I always pay a little bit more for that detergent. So I just think those issues are going to continue to factor in as we move forward.
Kenya, this is Tom. Just from the reputational standpoint, I think that's a huge risk. That a lot in the rush to get the data out, a lot of organizations are overlooking the potential risk to their reputation, and that's why kind of, not that I'm biased or anything, but I think that as providers and then later on payers try to comply with this and develop strategies, I think it's really important to have the right people at the table to develop a plan of action and strategies, proactive strategies. And I would highly recommend that the chief marketing officer or your communications professionals be at the table, because they need to help you plan how you're going to tell your story. And that gets to Ben's point about, maybe you have a very, very good reason why your prices are higher because your outcomes are better in certain areas. But this kind of reminds me, and maybe I'm showing my age, but this kind of reminds me of when mortality data was first released and hospitals tied themselves in knots trying to message around why they had higher mortality rates. The risk model is off. We have sicker patients. I can kind of see people going down that same road now. You could twist yourself into knots trying to explain your pricing. Also, I think this gives hospitals a great opportunity to explain this is just one piece of your overall total cost of care. And there's a whole lot of other factors that determine what your final cost is going to be, depending on, you may identify the lowest cost provider, that's got high quality. That provider may not be in your network, may not be in your contracted network. Your doctor may not go there. There's a whole bunch of different reasons, but just from a PR standpoint, don't forget the communications folks when you're developing your strategies.
Mm-hmm. And Dan, you had Kristen.
Oh, I was just going to say your question was about HSAs, and Hirsch, thank you for asking it. There is no evidence that I've seen that HSAs have in any significant way moved cost, have changed an enormous amount of behavior. I love them because they give me a tiny tax break. Thank you. But it hasn't been the thing that has worked, and it makes a lot of sense that it doesn't. Consumers a long time ago abdicated really a lot of their direct relationship to cost and paying for care. And, while we're moving a lot of the costs back onto them with some of the changes in their insurance plans, their employers, there's no elasticity for demand in a lot of the things that are very expensive in healthcare anyway. The things that are really going to hit you, you have to buy. And HSAs, frankly, let's, say you put $5,000 into one a year, you do something like that, that isn't going to really be helpful when you have a $50,000 bill. It's just not for something you had to have. So I just don't see it as part of, it's fascinating that people thought it would be a really great solution. I don't see it impacting the industry overall very much. I don't want to say it's bad. I still want mine. Thank you. But I don't think it's going to move the world at all. And I think that other organizations, you mentioned, we're going to have an Amazon buying thing, maybe, but I don't think HSAs will be a big part of that.
Dan, did you have anything else to add to that? I know that you added that the out-of-pocket costs are so high with the HSAs that not as effective as we thought they would be.
Well, I think when you go with when HSA and high deductible health plans came out, there was a big price disparage between, hey, I was paying $500 for a copay plan, now I'm getting $200 for an HSA. There's a $300 difference in premiums. The goal of it was, I'm going to tell the employee, hey, you're saving $300 a month, put that in the HSA account. Now, when we look at the numbers, they're almost the same. You're getting basically a crappier plan for the same amount on the PPO plan. So, they see that, but you look even at the numbers from 2018, only 50% of Americans go into a high deductible health plan. And why do they do it? Most of them do it because it's the cheaper of all the plans available. Only 14% actually put money into an HSA account. So you've taken 86% of the population, forced them into a plan that has crappy coverage, and they have no money in the HSA account to afford the deductible. So it's gone against the exact purpose of what it was started for.
Speak, brother.
I'll tell you, 90% of our clients don't even have an HSA plan anymore. They went back to copay plans, and we've gone lower deductibles because we're controlling the cost. We're actually controlling that healthcare logistics, and controlling that cost allows us to give better benefits at a lower cost to the employees, where they can actually use it for healthcare.
A lot of the transparency issues and that issue too. We're talking about cost, guys. We're not doing that. We're not doing this just to describe it or to report it, or we're trying to get the cost of care where people can afford it. Much bigger topics really behind all this.
Yeah. And Trey adds that. Oh, go ahead, Ben.
Well, I was just going to say, I think that's one of the points I was trying to make at the very beginning of that. When we think about HSAs, high deductibles, all this cost sharing, that all is the utilization side of the equation. Like if medical cost is utilization times price, essentially on a per capita basis, what's the growth of that year over year? Utilization, that's all on that side. And so I think going forward, we're just going to see more and more focus on the price part of the cost equation.
Ben, wouldn't you agree that most of the studies that have come out lately don't show that Americans overutilize? I mean, we're not using a ton. I mean, there are markets, there's discrete things that we use more, but overall, we're not utilizing. We use less than
in Japan and many European countries. It is a little bit of a misnomer that we're super high utilizers up here. That's absolutely right.
Well, and Trey added, that what consumers are really wanting is to know what it's going to cost them, what's their out of pocket going to be. And, this doesn't necessarily get them there.
I don't think that the price transparency rules or the transparency rules that are presented that the hospitals or others are being asked to do are going to answer that question, Trey. And there's many reasons for that. I mean, Steve Love has put in the chat, what about people who smoke and are obese and things cost more? Yeah. I mean, that's part of it too. You're not going to be able to answer the question. Things happen. You're not going to be able to answer the question. I take my car in to get serviced. I don't know what it's going to cost. And this is more complicated. So, I mean, they diagnose you when you get there, and then you start working backwards on what it might cost you to do certain things. So I just don't think this, it's nice to have a ballpark, I guess, an estimate. People give you estimates often, and that's not what you pay. If you've ever redone a house or gotten your car fixed or whatever, an estimate is an estimate is an estimate. And that's not bad information. It's just that I don't think that solves the consumer problem. How much is this going to cost me? I feel buried by these costs. And the truth is that sometimes after the provider says what they're going to do, let's say you go in and you have a diagnosis and they tell you you're going to need a surgery for X or whatever. The next best person maybe to tell you what it's going to cost you is the person you have a relationship with for your insurance. And I say that because they know your exact coverage and they know what providers they're contracted with, and they have those details. When I've had something expensive, cancer surgery, and follow. I mean, I asked the insurer, where are we? Who are these people? Are they in? How does that work? And I knew I wasn't going to get it exactly, but I knew that I would make sure I didn't go out of network, that I didn't get the big hits, for the work. I feel like the stuff that's online, I mean, people barely check to see the mortality rates, and that's whether you live or die for something. I'm not sure people are going to go check that and try to go through all that detail and try to figure it out.
I think, Kristen, you're bringing up a really great point, which is what exactly do the consumers really want? And right now, there's kind of a golden age of access points. They're already having to make all these different decisions about, do I go in? Do I do virtual? Do I do a retail? There's like 1,000 different access points for care right now anyway. And on top of that, it's like, and I'm supposed to go and get data and shop around and things like that. So, I think it brings up really the question, is the consumer the right place to kind of place all this decision point on? Or is it really information and data that should be used by payers and employers to figure out what kind of network they want to set up and who they really want to work with? And so the consumers aren't really having to make that choice on a day-to-day basis. Last thing I'll just say is really what I see from our consumer surveys is consumers want certainty. It's really hard to budget for healthcare, right? Yeah. And that's a big challenge. And I've noticed that in some of the retail health clinics and the urgent care clinics, they're putting together like Happy Meal menus, right? You come in and it's like, maybe have an uninsured price, right? $100 or $120, and it's a menu of all the things you're going to get, right? You're going to have that visit. If you need an X-ray, that might be included, or might be $20 more. If you need lab work, that might be included. So what it's doing for the consumer is it's saying your worst case scenario, even if you're uninsured, you come to us, you're going to be $100 out of pocket, and that's the kind of stuff that consumers want. The next level is that $100 a good deal or a ripoff?
And I think most of us have employees or friends or both that we talk with them about this what do I need from a certainty standpoint? How can I be safe financially from a disaster in healthcare? And let's say you're talking about an insured person, not an uninsured person, which is a whole different, different level of considerations. My advice to them, whether they're an employee or just a buddy, it's your out-of-pocket maximum. That's what you should have every year, all the time. I mean, on every plan. Everything else is working the margin. And that's expensive for people, because if your out-of-pocket cost can be a maximum of 20 grand a year, you need 20 grand in the bank in case that's tough. I mean, I understand that, but realistically, that's the number, and the rest is working pieces.
I would just say one other thing about where the public is, and this is probably going to add to the confusion once they see some of this data. But I think especially for multi-hospital systems, when they see the variation in cost for let's say a knee replacement or some kind of a procedure, and they're going to look across a multi-hospital system and they can see the tremendous variation in cost, they'll understand, this is the part of telling your story. They're not going to understand why does it cost much, or even just among competing hospitals in a marketplace. Why is it costing $20,000 at one place and $5,000 at another place? We don't understand. And so this just goes to adding to the confusion. And I think the public, for the most part, thinks that hospital costs and pricing, healthcare costs and pricing is a mess anyway. They don't understand it. They think that that the industry is trying to hide something because they just don't get it. So there's I think cost variation though is going to be a key issue and I think a lot of hospitals, finally I'll say this, I've heard a lot of hospitals say, well, consumers really aren't going to pay any attention to this because it's going to be too confusing. I will say they're not going to pay attention to it until it becomes a media story in their market. Once the media latches on to this and starts covering this, it is a story and people will begin to pay attention.
Well, on the question of whether this really controls prices or does it establish a floor? I mean, Dan was saying Medicare is the floor. Is there going to be a new floor potentially because people are competing on this pricing? Or a lot of this discussion just takes me to talking to providers, especially doctors, that say, what difference does it matter what we charge? The payers are going to pay us whatever they want to pay us anyway. So is the more relevant data what we're going to get from the insurers next year? Or, how does that what's the interplay there on pricing?
I think the insurers will be more useful. I think I said that earlier, but I honestly, I agree with Tom. I mean, in a general sense, there's going to be some stories, and your marketing team, your PR teams better be ready. You're right; they should be involved already. I just don't think. I think there are too many variables. Even if you try to give a good faith estimate as a provider, whether you're a physician or a health system or whatever, you're going to make it very clear why it's an estimate. That you as an individual may have things that happen that are no fault of anybody's. That's just the condition of, and that could cost you differently. So, and I think most people understand that. They don't like surprises. And I know Ben took surprise billing off the table, which we can spend all day. And I, boy, talk about something that needed to be taken care of. I mean, that's uncool, the surprise billing issues, but the pricing issues, I really feel like, if you want to know things ahead of time, the insurer information is going to be the very best information for each individual person as a consumer as they go forward. And I also think that this is a great opportunity for us to say we're not hiding anything. And what we'd really like to engage with you on is talking about why things cost so much versus the pricing transparency.
I think the only thing I would just add to that is, I think the other area to consider here are the third party or companies that are going to use this data, and they're going to work with employers who are willing, or in some ways the first time, to have a truly narrow network for their employees, and that's a big change from what we've seen before in employer-based health plans, which are usually like everyone's in the network no matter what. So where there's competition in a marketplace and an employer is willing to do a narrow network, they will have access to a lot of data that's going to help set where they think they're getting a good deal for their healthcare purchasing. So the business groups on health, the regionals, the nationals, the purchasers, they're very interested in this. And I'll even say, that there's, and again, no big secret I'm revealing here, but there are some employers who are getting pretty frustrated, even with their own insurance. I mean, their own TPAs, that they're not getting the deal, the negotiation that they really want. And they feel like, well, because it's not their money, it's my money, that no one's really watching the store. Now, I don't have a good crystal ball into terms of how this will actually play out. I can just say from our employer surveys, there's interest there. From the consumer surveys, obviously there's always interest in lower cost care. And I think the question is going to be, will some of these third parties, companies come in and actually use this data to provide better things for narrow networks, reference pricing, bundle payments, things like that?
And I think Ben is spot on. I think that's where this will be the most useful. Absolutely. Which just brings the point back question you asked Kenya about providers. You need to focus on real cost. You need to be able to explain why things cost what they cost, and be able to also show why your pricing brings the best value. Okay, why your costs bring the best value to the people that are being purchased for. But yeah, no, I agree with you. I think there's a great opportunity for another administrative cost analysis of all of these prices so that we can pick cheaper providers. Yeah.
I don't know. And I will say, we research this all the time, and the quality of the provider doesn't always mean that they are the most expensive. In fact, when we look at the ratings, many times the lower cost providers are actually the best. And why? Because they're having better results. They have less people coming back. But on some Tom said about pricing, I want to bring this up. We just did this last week. We have a system called MediV that we use for pricing comparisons. And it was a surgery. Medicare pays $16,000 for the surgery. That's what Medicare's pricing is. And we searched 6 hospitals in DFW. And they range from next one was in 35, 40 range. Next one was 60 something. There was a hospital in Fort Worth charging $120,000 for the exact same procedure that Medicare pays $16,000. And what happens is the employee says, well, I have to pay a $3,000 deductible. It doesn't even hurt them. My max out of pocket is $3,000. It doesn't matter where they go. But as an employer and an advocate for the employers, if I'm self-funded, you just cost my plan an extra $100,000 that I didn't need to do. And what do I do now? My claims go up, my stop loss goes up. Now next year when renewal comes, I'm having to put that on the back of the employees in higher premiums. So again, that cost control has to happen on that higher level. And we have to have some way to control that and understand why are they charging 6 times Medicare. And the average in Texas is 650% Medicare. And that's absolutely ridiculous. And even if you say, well, I have a Blue Cross or I have a network discount of 50%, I'm still paying 3.5 times Medicare, what Medicare is paying. And I know for a fact hospitals are profitable at, even when they're getting 105% Medicare. I've had discussions with hospital CEOs before. So it's just, we've got to get that transparency and that control somehow.
I think Dan's points are fair. I would say this though, and I mean this, the reason things cost so much aren't always dependent upon everything that the provider themselves can manage. These are huge public policy issues. There's an enormous amount of cost shifting, as you know, because of our large uninsured rate. There are, while employers, I think Commonwealth said last year that Texas had the 4th highest insurance premiums per person in the United States, something like that. Very high for our usual cost of living, I say it that way. When you have 20-25% uninsured and the cost shifting's occurring and all this stuff, that's gonna impact it. But what's hard is you can't unwind how much is what. You can't figure out, is it, does it go up 20% because of that? Does it double? Because how do you sort it? Because costs don't align with service delivery. and so it's a macro issue. Some things, and I'm sure you're right. I worked in a health system for 10 years at the executive level, and certainly at 105% of Medicare, you could make money on some things, and sometimes you'd lose your shirt on a different type of procedure. It isn't an across the board 105% of Medicare will make you money. So it's because Medicare, frankly, doesn't always track costs directly to exactly what's going on, or Medicaid, obviously. So I think that it's complicated it's complicated beyond the direct relationship issue that normal business people think about. And it's one of the hardest things to explain to business people, is to say, God, Steve Love's on here, and I love his car analogy where you have your BMW dealership and every fifth car is free or every fourth car is free. So if you're the BMW guy and you don't know what the fifth guy is going to ask you for, you have to price up the three before it at the most expensive Beamer. You're going to make money on that because not everyone will buy the most expensive Beamer, but at least you've covered your cost in case they do. There's crazy stuff that goes on because of our misalignment on who the payer is, on what we have to do for free and what we don't have to do for free, and especially in a hospital environment. It is a lot easier, I think, as we've talked about on some of this price transparency, to make some ground for consumers in the outpatient environment, where you don't have any emergency stuff, and things are less complicated. But it's a fascinating problem. And it is a great opportunity for people who want to work for employers, I think, to refine their choices for their employee coverage.
And I think, Kristen, to your point, I mean, one area I do see a big challenge, that's with our academic medical centers. They just have a higher overhead. And when we look at their mission of, medical education and research, the reality, and it's been this reality for a very long time, is that the actual health system part of the enterprise subsidizes the other parts of the enterprise. And so I do think, there is a danger if we just look at price without some sort of rationalization, especially on the federal government side, that we could get into trouble with some of our big research institutions and medical schools and others that are trying to provide care. Now, the question is, but I think the other part of that is, well, is there anything they can do? And I think, healthcare has generally been a very bricks and mortar intensive infrastructure. Those that have the trauma centers and the research, they got to carry that load for the whole community. And it's a lot easier to be a nimble, new telehealth company. You don't have all those costs associated with you. But one of the things I'm hearing from health system CFOs is they actually are finding some ways to truly cut costs. I mean, one thing that happened with the pandemic is, like, take, for example, all the business office folks. So, the folks doing the revenue cycle work and the AR and all that. I mean, those people were all sitting in actual office space, sometimes in downtown areas. And they learned for the first time that you could actually have all those people work from home. And now I'm hearing them say, like, well, I'm in a 2-year lease, but when my lease is up, we're dropping that. And that's going to be, we're going to take our, 200,000 square feet down to 20,000 square feet. We're going to save $2 million a year. So, I am starting to hear a change in tone. I think some of it is because of price transparency, consumer demand, other pressures. Some of it is because they've learned that they can work differently, especially the non-direct patient care, and move themselves into a lower overhead setting.
So Ben and Kristen, do you think that the whole price transparency issue may drive more discussion about Medicare for all type system, or a more universal payer type system? Do you think it's going to drive discussions toward that more? Would that be more of an impetus as people begin to try and sort their way through this and either get frustrated or more confused or whatever?
Kristen, do you want to go first?
Question. I'm not sure price transparency will be the driver of that discussion. I mean, I guess it wouldn't hurt any attention you bring to problems with, the cost of care, including transparency that might show huge differentials, like Dan described, $100,000 difference. That's, to me, that's definitely a great example of something outrageous you'll see, and it has to be resolved one way or another. I'm sure those are going to pop out. I'm trying to think of the explanations that would be for that, and I'm not that creative, so I don't know what to say. But I'm not thinking that will drive it. I think from a policy standpoint, there are too many political opinions behind that for practical things to necessarily be the driver of the conversation. I apologize for saying it that way, but that's my perception. I think that's a different bag of snakes.
Kristen, first of all, I love that, by the way, that the way you describe that, because it's probably the most accurate description of what would or wouldn't drive. It won't be like actual data-driven, pragmatic decision making.
I wish I could say it was. You know what? I'm getting older, and I don't have enough time to that too much. I'm just gonna say it now.
But I agree with that. I think that we have these perceptions in our society that need to get into reality. The reality is that the American health system is almost exactly half equally paid for by government and taxpayers, and half by, quote, private industry and employers and consumers. And even that is like even more and more mixed as more of our government insurance is actually implemented by private payers as well. Many who are doing a great job with that. So, I think when we talk about something like Medicare for all, if there's anything that was going to happen, I think we'd see an incremental move and this is something the Biden administration has talked about, is actually lowering the Medicare eligibility age to 60 or having some sort of, buy-in. I'm not sure exactly how that would work. But, I think this is what we tend to do in this country. We keep peeling off these areas of folks who are uninsured. That's a tough age, that 60 to 65. For a lot of folks, they're not yet to Medicare. They may be, you're kind of in the twilight of your career, first to get laid off, right? And so that's a tough piece. So that might be an area to peel off more uninsured. So I would look to that. I'm not saying that's around the corner. I'm just saying I would look to that as an interim in that area. And it kind of relates also to the issue that we have right here in Texas with the expansion of Medicaid. And we have to all these southern states have to come up with all these ways to act like we're not expanding healthcare. We have to call it something else. We have to do something, to try to get this done. And that's where we have that real bifurcation between data-driven pragmatism and kind of political, outlook.
Well, this has been a great discussion. Thank you guys so much. Great. Thank you to our active audience. There are so many different perspectives on this. So thankful for all of you contributing as well. This will be an ongoing issue that we will continue to monitor just to see how it continues to play out, both on the enforcement side as well as on the practical and operational side. Any other comments from you, Ken, as we wrap up?
Well, first and foremost, shame on me. I neglected to recognize Kenya and what role she plays in this healthcare continuum. But she and her partner, Cheryl Kamen Murray, are partners at the law firm of Catton, and they do great work from a healthcare perspective, and we appreciate their engagement in everything that happens in this community. But just as importantly, we also want to recognize Ben and Kristen for being here today. On behalf of the North Dallas Chamber of Commerce, we will be making a donation in your name to the Austin Street Shelter, and by the way, to you as well, Kenya, to the Austin Street Shelter at the end of our fiscal year to recognize all of our speakers. But we really do appreciate y'all being here, sharing your insights, great perspectives today on a very important topic. And thank you so much for the time. Ben, thank you particularly for preparing that presentation today. Hopefully you'll get to use it with many of your other clients, but thank you very much for the time on that as well. Kristen, I know you're about ready to head out of town, so we really appreciate your engagement today. Thank you very much for that as well. And to all of you who came and are participating in this North Dallas Chamber of Commerce Healthcare Committee, we appreciate your engagement. We expect between Kenya and Stephen Angelette, myself, and others, we expect to have another conference or a meeting like this probably in about 3 months. And then at that point, we will be preparing for our annual healthcare conference, which is our big event of the year in January of 2022. So keep your eyes and ears open for a lot of other activities occurring at the North Dallas Chamber of Commerce. Just go to ndcc.org. Calendar is full. There's a lot of activity.